أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. So welcome back guys. Today we are going to study about some of the important clinical findings regarding Mycobacterium tuberculosis. This is the second lecture regarding Mycobacterium tuberculosis. In the first lecture we have discussed the important points regarding this Mycobacterium tuberculosis, their pathogenesis, how they cause disease, and the types of tuberculosis like primary tuberculosis, secondary tuberculosis. Today we are going to study about the clinical findings which are caused by the Mycobacterium tuberculosis. So let's start. So first of all we will study about the common symptoms caused by Mycobacterium tuberculosis, which are like fever, fatigue, night sweats, and the weight loss. These are the common symptoms which are mainly caused by all types of bacterial infection. So they are not so much important with regard to the clinical findings. The second uh, clinical finding, which is the pulmonary tuberculosis, and this pulmonary tuberculosis is characterized by the cough and the hemoptysis. This is characterized by cough and the hemoptysis. So what is hemoptysis? Hemoptysis is the blood in the sputum. It is blood in the sputum. The third clinical finding is the cervical lymphadenitis. And what is cervical lymphadenitis? It is a swollen, non-tender lymph nodes which are present usually unilaterally. This is scrofula is the cervical lymphadenitis, which is a swollen, non-tender lymph nodes which is present usually unilaterally. As you can see, the scrofula caused by the Mycobacterium tuberculosis. Now coming to the third clinical finding, which is usually a hypersensitivity response to the Mycobacterium tuberculosis, and this is called erythema nodosum. And erythema nodosum is characterized by the tender nodules along the extensor surface of the tibia and ulna. Characterized by the tender nodules along the extensor surface of the tibia and ulna, and they appear in people who control the infections with potent cell-mediated immunity, i.e., those people which have a strong cell-mediated immunity against the Mycobacterium tuberculosis, they present with such kind of symptom like erythema nodosum. You can see the erythema nodosum is the non-tender. You can see the erythema nodosum as the tender nodules along the extensor surface. This is the extensor surface of the tibia and ulna. You can see. The fifth clinical finding is the intestinal tuberculosis. As we have already discussed that Mycobacterium tuberculosis causes two types of tuberculosis. First one is the pulmonary, and the second one is the extrapulmonary. So it is one of the type of extrapulmonary tuberculosis, which is called intestinal tuberculosis, and it is characterized by the abdominal pain, diarrhea, fever, weight loss, which can lead to intestinal obstruction and hemorrhage. The seventh clinical finding is the oropharyngeal tuberculosis, which is characterized by the fanless ulcer in the mouth and adenopathy. As you can see in this picture, you can see the fanless. It is the ulcer which is fanless. The eighth clinical finding is the renal tuberculosis, which is characterized by dysuria. Dysuria means no urine, hematuria, blood in the urine, plague pain, and characterized by biochemically by the steroiduria, in which there are RBC but no bacteria, and the Mycobacterium tuberculosis culture is positive. Now talking about the complication caused by the infection of Mycobacterium tuberculosis. So the complication caused by the Mycobacterium tuberculosis infection are the following, like malaria, which is we have also discussed, disseminated tuberculosis, in which the bacteria enter the blood causing bacteremia and spread to all organs. Second one is the tubercular meningitis, i.e. meningitis caused by Mycobacterium tuberculosis. The third one is the osteomyelitis, which is especially vertebral osteomyelitis, also called as Fort's disease. And this osteomyelitis is caused by the Mycobacterium tuberculosis. Talking about the lab diagnosis, how we would diagnose that the infection is caused by Mycobacterium tuberculosis. So we use the following methods like microscopy, by culturing the specimens biochemically, and the fourth one is the test for the latent infection. This test is done for the latent infection. The first one, coming toward the first one, which is microscopy. So we use two types of staining. The first one is the acid fast staining, and the second one is the auramine rhodonamine staining. Auramine rhodonamine staining. In the first one staining, as we have already discussed, that the Mycobacterium tuberculosis is an acid fast bacilli, acid fast, so they can't be stained by the ordinary gram staining easily. So we use the following staining like Z-Nelson stain and the Canyon stain. And on such staining, the colony can be seen as rod colonies. On Z-Nelson and the Canyon staining, the Mycobacterium tuberculosis colony can begin as red colonies. As we can see the Z-Nelson staining, in which you can see the red colonies caused by the Mycobacterium tuberculosis. The second one is we can also see the Canyon staining, which you can see the red colonies like this. These colonies are of Mycobacterium tuberculosis. The second staining is through the fluorescent microscopy, and we use the auramine rhodonamine stains for the fluorescent microscopy. And on auramine rhodonamine staining, and when seen on fluorescent microscope, we can see the yellow orange colonies of Mycobacterium tuberculosis. You can see the yellow orange colonies of the Mycobacterium tuberculosis through fluorescent microscopy using the auramine rhodonamine staining. The important point regarding the staining is that their sensitivity is too much low, and about 50% of the smear which can be seen as smear negative are usually culture positive. It means that its sensitivity is very low. Now coming towards the culturing, which is the second method of diagnosing Mycobacterium tuberculosis. So in order to do culture, we have to follow the following things. We have to follow the following things like we have to frustrate the specimen with the sodium hydroxide and then centrifuge it. The purpose of centrifugation is to solubilize or remove the viscous mucus, and the purpose of centrifugation is to concentrate the Mycobacterium tuberculosis. So we use two types of medium for the culturing. The first one is the Lewinston-Jensen medium, and the second one is the Bactic medium. So talking about the Lewinston-Jensen medium, it consists of complex nutrients like egg yolk, dyes like malachite green, and antibiotics whose purpose is to inhibit the other bacteria. And this Lewinston-Jensen medium shows Mycobacterium tuberculosis colonies in about 3 to 6 weeks. And they can be seen as brown rough colonies. So the Lewinston-Jensen medium requires a lot of time, 3 to 6 weeks. So before diagnosis through this culturing, we have to start the empirical therapy. You can see the brown rough colonies. Of Mycobacterium tuberculosis in the Lewinston-Jensen medium. The second one method for the culturing is the Bactic medium, which contain radioactive metabolites, and the growth of Mycobacterium tuberculosis can be detected by the carbon dioxide production within 2 weeks. Within 2 weeks, it is a faster method than Mycobacterium tuberculosis. The third one is we have already discussed. Third method for the diagnosis of Mycobacterium tuberculosis is through the biochemical tests. So we have two kind of tests. The first one is the we can diagnose it by the production of niacin, and the second one is this Mycobacterium tuberculosis is catalase positive. Mycobacterium tuberculosis produce niacin, and no other bacteria can produce niacin except Mycobacterium tuberculosis. So this is the first one method, and the catalase positivity is the second method for the diagnosis of Mycobacterium tuberculosis. Now as we have discussed that we also need to diagnose the latent infection which is dormant caused by the Mycobacterium tuberculosis. So for this we use two types of tests. The first one is the PDD test, and the second one is the interferon gamma assay, interferon gamma release assay. And this interferon gamma release assay test can be further divided into quantiferon TB gold and the T-spot TB. First talking about the PDD test, which is also called Mantoux test, and this Mantoux test is the standard method of determining whether a person is infected with Mycobacterium tuberculosis or not. In the Mantoux test or the PDD test, a protein called tuberculin purified protein derivatives, which is derived from the Mycobacterium tuberculosis, it is injected into the usually the skin of the forearm and then seen for the duration. So how to interpret the PDD test? So when the size of the duration measured by a ruler is 15 mm and above, it signifies that it is a Mycobacterium tuberculosis infection. It is a Mycobacterium tuberculosis infection. So when the size of duration is 10 to 14 mm, then it can be interpreted as it is an BCG induced sensitivity. Now when the size, the third possibility is when the size of duration is 5 to 9 mm, then there is the Mycobacterium tuberculosis infection, but usually in the immunocompromised people. And when the size of duration is less than 5 mm, then it indicates no Mycobacterium tuberculosis infection. So summary: when the size is 15 or more, then signifies Mycobacterium tuberculosis infection. When the size of duration is 10 to 14 mm, then this can be caused by the BCG. We will discuss how BCG cause positive PDD test later in another lecture. And it can also show the infection with Mycobacterium tuberculosis. When the size of duration is 5 to 10 mm, then it can be Mycobacterium tuberculosis infection, but it is mostly in the immunocompromised people. And when the size of duration is less than 5 mm, then there is no Mycobacterium tuberculosis infection. Now we have already discussed that we can diagnose the latent infection by two methods. The first one is the PDD, and the second one is the interferon gamma release assay. So talking about the interferon gamma release test, so this is the blood test to determine the Mycobacterium tuberculosis infection, and this is done by measuring the cell-mediated immunity to Mycobacterium tuberculosis. In this test, we measure the interferon gamma, which are released by the sensitized WBC in response to the Mycobacterium tuberculosis antigens like ESAT6, CFP10, and TB7.7. These all are Mycobacterium tuberculosis antigens. There is no cross-reactivity to BCG in most antigens, and this do not differentiate latent infection from the active disease.